Welcome to the Deep Dive, where we cut through the noise and get to the heart of complex topics. Today we're doing a deep dive into an extraordinary book, Till We Win, India's Fight Against the COVID-19 Pandemic. This isn't just another account, It offers a unique inside perspective from three really eminent Indian experts. We've got Dr. Chandrakant, a public policy and health systems expert, Dr. Gagandeep Kang, an infectious disease researcher, and Dr. Randeep Guleria, a world-renowned pulmonologist and director of AIMS New Delhi. Their combined expertise, it gives us incredible insight into India's monumental response.
That's right. This book gives such a detailed look at the scientific, public health, and societal challenges India faced, all seen through the eyes of those right there on the front lines. And it also packs in crucial insights, from policy lessons to practical tips for just everyday living during a crisis like this. Our mission today is really to unpack the most crucial lessons and maybe some surprising insights from their experience, sort of offer you a direct shortcut to understanding the colossal effort involved.
Okay, let's unpack this then. Our journey, it really begins with understanding the enemy itself, viruses. What the book highlights is how remarkably recent our understanding of these microscopic foes truly is. It's quite amazing. Imagine pioneers like Edward Jenner, Louis Pasteur. They were developing vaccines without even knowing about viruses. Yeah. Or, their intricate life cycles.
Right. It's hard to fathom now.
It wasn't until the late 19th century that scientists like Dmitry Ivanovsky and Martinus Beijerinck identified these filterable agents, basically something even smaller than bacteria. Beijerinck famously named them viruses. And this foundational discovery, as the authors really underscore, it set the stage for all modern virology. Yeah. And profoundly shaped how we approached COVID-19.
And that leads us straight to a key distinction. The authors clarify the progression of disease spread. We've all become pretty familiar with terms like epidemic and pandemic, haven't we? The book highlights how COVID-19 perfectly illustrated this. It started as a local outbreak in Wuhan, China. Then it rapidly exploded into an epidemic as it spread across Asia before, escalating into the global pandemic that the WHO declared. This rapid interconnected spread is just so characteristic of modern health crises.
So what does this all mean? Why do these new infectious agents keep emerging and spreading at such an, accelerated pace, especially in recent decades?
Yeah, that's a critical question.
The authors point to several key accelerators. For one, increased global travel.
Huge factor.
An infected person can carry a pathogen to almost any major city in the world within, 24 hours?
Pretty much, yeah.
And our cities are growing, becoming more crowded. That means more frequent, longer contact. Then there's deforestation, which increases human-wild animal contact, allows hidden viruses to find new hosts.
Right, jumping species.
Climate change, too. Pathogens can survive longer, spread to previously cold areas. We're also creating conditions ripe for spread in animals and birds through practices like battery farms. And even widespread antibiotic use contributes, leading to drug-resistant superbugs. It's a complex mix.
It really is, and this brings us to a crucial point the book makes. Why are influenza viruses so often considered the prototype for pandemic agents?
That's interesting. Why influenza specifically?
Well, here's why influenza is such a notorious pandemic threat. Its genetic makeup is kind of like a puzzle. Unlike many viruses, its genes are split into 8 separate RNA strands, or pieces.
Okay.
This structure makes it incredibly easy for different flu strains, say one from a duck and one from a human, to swap pieces if they happen to infect the same host cell. That genetic mashup, that reassortment, can instantly create a completely new, potentially dangerous virus. And that's precisely why it's our sort of prototype for pandemic agent.
Wow, okay, gene swapping.
Exactly. And this risk is amplified when humans live closely with domestic animals like ducks, chickens, or pigs, which harbor many influenza viruses of their own. We saw this clearly with the 2009 H1N1 swine flu virus. It actually had genes from pigs, humans, and birds, a real mix.
Right, I remember that. So how did COVID-19 stack up against previous coronavirus challenges like SARS?
Good comparison.
Back in 2003, SARS-CoV caused a severe respiratory illness. It did spread globally, but it was controlled relatively quickly.
Right, because it primarily caused lower respiratory tract infections.
Meaning the virus was only really released after a person was visibly sick, so isolating patients worked.
Exactly. And it disappeared by 2004 with around 8,000 infected, a serious outbreak, but contained.
Contrast that with SARS-CoV-2, the virus causing COVID-19.
A completely different beast in terms of spread.
This virus infects the nose and upper respiratory tract much more readily, making coughing and sneezing incredibly effective spreaders.
Much easier transmission.
And even more critically, An infected person can be infectious for, what, 2 to 3 days before symptoms even appear.
That's the killer part, the pre-symptomatic spread.
Or they might remain asymptomatic throughout their infection. The book estimates maybe 25 to 40% of all infections.
Yeah, a huge chunk.
So this wide spectrum of illness, from no symptoms to critical, and especially that pre-symptomatic spread, it made it a vastly bigger challenge, didn't it?
Absolutely. A game changer for public health response.
Okay, let's dive into what the illness itself actually looks like. The book details a really wide spectrum of clinical symptoms for COVID-19, and it categorizes them very clearly.
Yeah, that clarity is helpful.
First, there are asymptomatic or pre-symptomatic cases. People test positive but show no symptoms, or symptoms develop later. Crucially, they can still be infectious.
Spreading it, yeah.
Then you have mild cases. Symptoms like fever, cough, sore throat, tiredness, headache, muscle pain, maybe nausea, vomiting, diarrhea, and that very distinct loss of taste and smell.
Which became a real hallmark sign.
But importantly, no shortness of breath, normal oxygen saturation. Moving on, moderate cases. Here you see difficulty breathing, maybe abnormal x-rays or CT scans, and a fall in oxygen levels, usually below 94%.
Right.
These patients often need supplemental oxygen. And this is where pulse oximeters became, well, routinely used by everyone, practically.
A vital tool for home monitoring, too.
And the severe cases, this means low oxygen levels, rapid breathing, significant lung damage, requiring high-flow oxygen, non-invasive ventilation, or even proning turning patients onto their stomachs.
Which actually helped a lot with oxygenation.
And then the most serious, critical cases. Here we're talking about conditions like respiratory failure or septic shock.
Which is that dangerous whole-body inflammation response.
Exactly, that overwhelming response causing dangerously low blood pressure. Or multi-organ dysfunction, where several organs, not just the lungs, begin to fail.
Tragic.
These patients, sadly, require intensive care, ICU care, and often ventilators.
This really drives home that COVID-19 is much more than just a respiratory disease, you know. If we connect this to the bigger picture, it's clearly a systemic illness. It can cause widespread damage. We saw sepsis, multi-organ failure, including acute kidney injury, cardiac injury. The virus can directly attack other organs. It can cause inflammation of blood vessels, promote clotting in the blood. Those microclots became a major concern.
Right.
And it can trigger that enhanced inflammatory response, often called a cytokine storm, though the term itself is debated a bit now.
Okay.
Essentially, the immune system overreacts and attacks the body's own tissues. This doesn't happen in everyone, but when it does, it can seriously damage many organs beyond the lungs, brain, intestines, skin, liver, the circulatory system.
And the potential long-term damage, long COVID, as we now call it.
Yeah, that's still being understood, but it's hard to predict. Some patients might develop permanent lung scarring. Heart muscle damage has been observed even in young, healthy people after mild disease.
Really? Even mild?
Even mild, yes. And COVID-19 definitely increases the likelihood of blood clots forming, which can lead to heart attacks, strokes, or damage to other organs like the lungs, legs, liver, kidneys. It's a complex, lingering picture for some.
So how did India respond as the world began to grapple with this new threat?
Well, the authors describe a cautious, yet pretty swift start.
Health authorities in China had alerted the WHO. Then cases started appearing nearby Thailand, South Korea, Japan. India's Ministry of Health and Family Welfare issued an advisory on January 17, 2020. Airport screening began just one day later, January 18th.
Pretty quick off the mark there.
The Joint Monitoring Group, the JMG, was activated to develop protocols, strengthen infrastructure. Then, on January 30th, 2020, WHO declared it a public health emergency of international concern, a PHEIC.
A critical moment.
And on that very same day, India reported its first case, a student who had returned from Wuhan to Thrissur in Kerala.
Yeah, that's when it became real for India. And what stands out is the immediate operational response, including what the authors call the real airlift.
The airlift, right. Tell us about that.
Imagine. The first Air India flight actually landed in Wuhan on January 31st, 2020, with a team of doctors and nurses on board.
Wow.
Specifically to evacuate Indian students stranded there. The quarantine strategy back home was very strict. Suspect cases went directly to the Army Research and Referral Hospital in Delhi. Others went to dedicated quarantine centers run by the Army or ITBP in places like Manasar or Challa.
And the precautions.
For the first time, staff at these facilities wore full personal protective equipment, PPE, and all quarantine individuals had to wear mandatory 3-layered surgical masks throughout their stay.
Strict.
Very. No one was allowed to leave without a genuine medical emergency.
Okay, so India managed these initial evacuations, set up quarantines, but once the virus was truly spreading within the country, how did they attempt to contain it?
Well, the book points to an absolutely monumental effort,
Hmm.
intensive contact tracing.
How intensive?
On average, for every single case detected, they aimed to identify and trace around 50 to 150 contacts.
That's a huge number per case.
It is. Call centers were even used for follow-ups in some states. But crucially, the real legwork was done by frontline workers. People like accredited social health activists, the ASAAs, and Anganwadi workers, the AWWs, they played a vital role.
How so?
They were literally visiting households, tracing contacts, doing regular follow-ups,
Yeah.
a true boots-on-the-ground approach. Essential work.
This brings us to the broader strategy, something often termed the hammer and dance theory.
Ah, yes, from that viral Medium article by Tomás Puello.
Right. His idea was basically hit hard first with an intense hammer, things like lockdowns, rapidly building healthcare capacity, extensive testing to really crush the initial outbreaks.
Stop it in its tracks.
Exactly. And then follow that with a sustained dance involving multiple lighter ongoing measures to contain the virus until a vaccine or other solutions became available.
A phased approach. So the natural next question becomes, what were the core public health interventions during that hammer and dance?
What did India focus on?
The focus was heavily on non-pharmacological interventions, basically face masks, hand washing, and social or physical distancing. The basics.
Things we all became very familiar with.
Absolutely. But these weren't just suggestions, you know? They required active government intervention through risk communication and community engagement, or RCCE. Yeah, communicating risks effectively and, crucially, preventing the spread of misinformation, which was rampant.
Sure.
And speaking of hand washing, it's remarkable how its significance just reemerged almost 170 years after its importance was first really demonstrated.
You mean Semmelweis?
Exactly. The book briefly reminds us of Ignaz Semmelweis in 1846 Vienna. He discovered the profound impact of simple hand hygiene on infection rates in hospitals, particularly maternal mortality.
An incredible story.
His groundbreaking work, later supported by people like Lister and Pasteur, firmly established hand washing's role in infection prevention. It truly is a proven, cost-effective public health intervention right up there with vaccination, and it proved crucial for COVID-19 once again.
Okay, so masks, distancing, hand washing. Another critical pillar of the response was test, trace, and isolate. How did testing evolve from those initial days? What were the challenges?
Oh, initially there were significant hurdles. Limited labs, limited testing kits, limited reagents. A real bottleneck.
What kind of tests were used first?
The gold standard then, and largely still is, RT-PCR, reverse transcription polymerase chain reaction.
Right.
This molecular test detects part of the viral genome, so it's highly sensitive and specific. Finds the virus itself.
But the downsides.
Well, it requires expensive lab setups, specialized equipment, trained staff, samples needed transport, often over long distances, and results could take anywhere from 5 to 7 days initially.
Which is a long time if someone's infectious.
Exactly. Pose a significant risk if individuals weren't isolated properly while waiting for that result.
So what came next?
Then, in June 2020, rapid antigen tests, or RATs, were approved in India.
How did they help?
The benefits were clear. They could be done right there in community settings, gave results within 15 to 30 minutes, and were relatively low cost, much faster turnaround.
But limitations.
Yes, the main limitation was their lower sensitivity compared to RT-PCR, meaning a higher risk of false negatives, the test saying someone doesn't have it when they actually do.
So a trade-off between speed and accuracy.
Pretty much. And throughout this, as you mentioned, ASAs and AWWs continued their crucial tracing role, tracking down 10 to 50 contacts per confirmed case. A relentless effort. And that tracing is linked directly to the next step, isolation and quarantine. Vital, but, as the book shows, also really challenging.
How so?
Initially, the policy was strict. Isolation for positive cases was exclusively in designated government facilities. Institutional isolation, they called it.
Okay.
Some states later allowed home isolation, but initially just for health workers. Then Delhi implemented home isolation for the general public from early May 2020, but only for mild cases.
Under what conditions?
Provided they had a separate room with an attached bathroom. And crucially, agreed to telefollow-ups by health teams. This strategy did successfully reduce the burden on healthcare facilities.
Makes sense.
However, the book really delves into the complexities, especially in unique situations like the Dharavi slum in Mumbai.
Right. Very densely populated.
Exactly. It was declared a containment zone, barricades went up, house-to-house surveys were attempted, but there was deep mistrust from many residents, leading to hostility towards health workers, a reluctance to share information or report symptoms. It just illustrates how absolutely crucial community trust is for any public health intervention to succeed. You can't force cooperation easily.
The lockdown was obviously a drastic measure impacting millions, but the book reveals it bought India crucial time. Time to do what exactly?
Time to rapidly build capacity and perhaps even more importantly, time to deepen their understanding of this completely new disease. The learning curve was incredibly steep.
So what did they learn or build during that intense period?
That's a key point. By the end of the lockdown, India had mobilized a tremendous amount of resources. The book mentions approximately 300,000 COVID-specific hospital beds and 700,000 isolation beds for mild cases were made ready.
How did they manage that?
Incredible improvisation. Schools and colleges were converted into COVID care centers, CCCs. State buses were transformed into mobile clinics. Even vacant flats in residential areas were utilized as CCCs.
Wow. Any specific state examples?
Well, Karnataka, for instance, undertook a really comprehensive household survey to identify high-risk people, exploring the potential of a broad public health database. Thinking long-term.
But it wasn't all smooth sailing, right?
Not at all. The book doesn't shy away from the difficulties. Delhi faced challenges like hotels actually going to court to resist government orders to convert their rooms into hospital beds.
Really?
Yes. Testing strategies also changed frequently, sometimes causing public confusion, and home isolation guidelines were modified multiple times.
And rural areas?
That was a major concern. In places like Bihar, the book highlights severe shortages, hospital beds, oxygen, ventilators, healthcare staff. Everything was stretched thin.
So the learning was often happening on the fly, under immense pressure.
Exactly. Revealing both incredible ingenuity and resilience, but also highlighting those deep-seated systemic weaknesses in the healthcare infrastructure, especially outside major cities.
You mentioned hostility towards health workers earlier.
Yeah.
This section of the book, dealing with the social impact, is really quite stark, isn't it? It illustrates the social and emotional toll.
It really does. The book reveals significant social biases and stigma faced by those on the very front lines.
Can you share an example?
There's a particularly poignant anecdote about Dr. Sanjay Gangard in Nashik. Initially, his housing society welcomed him as a corona warrior, clapping for him.
Right, I remember those scenes.
But after he himself tested positive while treating patients, the same society passed a resolution to actually bar his entry. He and his wife ended up isolating in a room at the hospital where he worked.
That's awful. Just awful.
It is, and sadly, not isolated. Similar stories emerged from Delhi doctors and health workers being ostracized, verbally abused in the streets, even asked to vacate their rented accommodation because landlords feared infection.
Unbelievable pressure.
And tragically, there were even racist slurs against people from northeastern India who were wrongly and horribly blamed by some for spreading the disease.
These stories of stigma, they're truly heartbreaking. It just brings home the immense psychological toll these frontline workers must have endured, fighting a pandemic and facing hostility from your own community.
Absolutely. The book really makes you pause and consider the immense courage and sacrifice involved, which leads us to a vital question the authors pose. What were the truly non-obvious, perhaps even painful lessons learned during this unprecedented period? What shifts in thinking really emerged?
Yeah, beyond the immediate crisis management, what were the deeper takeaways?
That's a crucial point, because the learning curve, as we said, was incredibly steep. One of the biggest takeaways, which might seem obvious in hindsight, but was a hard-won lesson then, was to implement known health interventions before searching for new ones.
Stick to the basics first.
Pretty much. We saw this play out with things like hand washing, masks, contact tracing, things we knew worked. Another huge one was that community participation is absolutely integral to health service delivery. It's not optional. It's essential for a well-functioning system.
Right. Top-down doesn't always work.
Exactly. They also highlight that health system strengthening is far more than just adding hospital beds. It encompasses both medical care and crucial public health services, prevention, surveillance, communication.
A broader view.
A much broader view. And a particularly powerful lesson hammered home was that health and economy are deeply interlinked. Investing in health isn't just a cost, it actually supports and enables economic growth.
That's a key message.
And finally, something that resonates globally. The authors emphasize that the pandemic is not over until it's over everywhere, highlighting that critical need for global solidarity and cooperation.
That focus on the system naturally transitions to acknowledging the people within it, the corona warriors, as the authors call them. Because it wasn't just doctors and nurses in ICUs, was it?
Not at all. The book rightly emphasizes that the pandemic was fought by everyone in society, but particularly the frontline health staff and essential service workers.
Well, who are we talking about specifically?
Doctors, nurses, community health workers like the ASHAs and AEWWs we mentioned, but also police officers maintaining order, sanitation workers handling hazardous waste, ambulance drivers, security guards. The list goes on.
And the book shares some truly heartbreaking stories of those who lost their lives in the line of duty.
It does. Dr. UC Ghosh, a 65-year-old Mohalla Clinic doctor in Delhi who chose to continue working despite being high risk. Ambika PK, a 46-year-old nursing officer, Constable Yogender Yadav, the 12th Delhi police personnel to die from COVID, and over 102 Brihan Mumbai municipal corporation workers in Mumbai, including sanitation staff who were collecting infectious biomedical waste daily. Unsung heroes.
There's a really powerful quote included from a nursing staff member. She said, "Initially, there was clarity on very few things. Nearly all of us had fears. But they know this is war. And soldiers do not run away in a war. They fight till the end. I will also do the same."
Chilling, isn't it? A sense of duty.
It truly underscores the immense need for dignity and respect for every single one of these workers.
Absolutely. And despite the immense challenges, the fear, the personal sacrifices, there were also countless positive stories of community solidarity and resilience that the book captures.
Like what?
Well, the Radha Swami Satsang Bees organization in Delhi, for example, prepared and distributed thousands of free meals daily to patients at that huge 10,000-bed COVID care facility they set up. In Arunachal Pradesh, groups of women organized themselves to serve hot meals to frontline workers on duty.
Small acts, huge impact.
Exactly. Recovered patients courageously returned to hospitals to donate convalescent plasma, hoping to help save others. Mortuary staff frequently overstayed their shifts, working under grim conditions to manage the increased number of bodies with dignity. ASIs, often leaving their own young children at home, continued conducting house-to-house surveys, contact tracing, identifying early symptoms. One Anganwadi worker in Bihar kept working despite a leg injury.
Incredible dedication.
There is even a 56-year-old state government employee who worked from 8 a.m. to 10 p.m. daily as a warden for a shelter home housing 400 people during the lockdown. And in Mumbai, a 35-year-old auto driver set up a community kitchen from his own savings, preparing meals for 250 to 300 stranded migrant workers every single day.
Wow. These stories really highlight that incredible human spirit that emerged even in the darkest times.
They really do. Against the backdrop of fear and uncertainty, there was also immense kindness and collective action.
Let's shift gears now to the science, which truly emerged as the real beacon of hope during the pandemic, didn't it?
Absolutely. Science was key.
In the early months, the book notes, responses were often empirical, based on past experience with similar viruses. But they quickly evolved towards evidence-based approaches as we learned more about SARS-CoV-2 specifically.
A rapid learning process.
Initial treatment strategies focused mainly on symptomatic care managing fever, cough along with close medical watch. But crucially, for patients experiencing breathlessness or declining oxygen saturation, simple supplemental oxygen was found to be life-saving.
Right, that became clear relatively early.
Which was contrary to some initial thoughts about needing early invasive ventilation for everyone. Hence, the importance of pulse oximeters and ensuring an adequate oxygen supply became absolutely paramount.
That oxygen crisis India faced later really highlighted how critical that basic intervention was. So the natural next question becomes, why was there such desperation for specific treatments early on?
What drove that urgent search?
Well, early on, mortality rates were alarmingly high in some places, reaching 5 to 10% in certain countries or hospital settings. There was immense pressure to find something that worked. This led to an urgent global search for existing drugs that could potentially be repurposed.
Like hydroxychloroquine.
Exactly. Hydroxychloroquine, HCQ, is a prime example. Initially, there was great hope, fueled by some small early studies.
Right.
But then large, well-designed, randomized controlled trials like the UK's Recovery Trial and the WHO-led Solidarity Trial, which spanned nearly 30 countries, ultimately found no benefit for hospitalized COVID-19 patients. In fact, potential harms were noted.
A tough lesson in scientific rigor.
Absolutely. It underscores why scientific rigor and large-scale trials are the cornerstone of modern medicine. The guiding principle must always be primum non nocere. First, do no harm. Unproven therapies, even if well-intentioned, have to be discarded if the evidence isn't there.
Can you quickly explain what makes a clinical trial rigorous?
Sure, in essence, a good clinical trial is a controlled study. It compares a new treatment against a standard treatment or a placebo, an inactive substance. Patients are randomly allocated to receive either the new treatment or the control. And often, it's blinded, meaning neither the patients nor the researchers directly interacting with them know who got what, to avoid bias in reporting or assessment. That ensures an unbiased measurement of any improvement.
Got it. So HCQ was out. What did eventually show promise?
By September and October 2020, evidence was solidifying that steroids, inexpensive drugs like dexamethasone and methylprednisolone did show a significant benefit, but specifically for severe cases requiring oxygen or ventilation.
Not for mild cases.
No, potentially harmful in mild cases, actually. Anticoagulants, or blood thinners, also showed benefit in preventing clots in hospitalized patients. Unfortunately, the big WHO Solidarity trial found no significant beneficial effect for the other therapies it tested initially, like lopinavir, ritonavir, interferon, or even remdesivir on mortality in severely ill patients.
So supportive care remained key.
Exactly. Good supportive care, including oxygen when needed and steroids when indicated, remain the mainstay for severe disease.
What about other drugs we heard about, like tocilizumab?
Tocilizumab. It's an immunosuppressant used for that cytokine storm we mentioned. Initial smaller studies showed some promise, but subsequent larger studies raised doubts about its significant benefit on mortality and even questioned whether the cytokine storm mechanism was the primary driver of severe disease in all patients, pointing more towards things like blood vessel damage or endothelial dysfunction. The science kept evolving.
It really highlights how dynamic this situation was.
And the book reminds us that recovery rates are actually very high, 98% or more overall. But there is the issue of long COVID, with lingering symptoms for some.
And antibiotics.
Crucially, antibiotics do not work against viruses like SARS-CoV-2. They are only useful if a patient develops a secondary bacterial infection, which sometimes happens in severe COVID-19 cases in the hospital.
We've talked about the challenges, the policies, the science of the disease itself. But for many, the true beacon of hope throughout this crisis was the science that delivered vaccines at an unprecedented pace. This section of the book is truly compelling, detailing that incredible race.
It really is astonishing when you think about it. Vaccine development usually takes years, decades even.
Right. The book recalls Edward Jenner and smallpox back in the 1790s and notes that inoculation might have been practiced even centuries earlier in India and China. A long history.
A very long history. But the pace for SARS-CoV-2 was just breathtaking. The viral sequence was reported publicly on January 11, 2020. Vaccine development efforts literally started the next day, January 12th.
Incredible speed.
Within just a few months, there were over 300 candidate vaccines in development worldwide. More than 50 were already in human trials, and about a dozen had reached late-phase, large-scale efficacy trials. Unprecedented.
And the book describes various different vaccine platforms, different ways of making them.
Yes, a whole range of technologies were employed. Some traditional, some brand new. Let's run through the main types mentioned. There were vaccines using the whole living SARS-CoV-2 virus, but in a weakened or attenuated form, like those developed by the Serum Institute and Indian Immunologicals.
Okay, weakened virus.
Then inactivated or killed whole virus vaccines. Here, the virus is grown and then chemically inactivated so it can't cause disease but still triggers immunity. Examples include vaccines from Chinese companies and the one developed jointly by ICMR and Farad Biotech in India, Covaxin.
Traditional approaches.
Right. Then protein vaccines. These use just a part of the virus, typically the spike protein or a piece of it, produced in a lab, to stimulate an immune response. Sanofi worked on this, and University of Queensland had an interesting molecular clamp technology.
Focusing on the spike.
Exactly. Then the really novel ones, RNA vaccines, a completely new platform for widespread use. Tiny strands of messenger RNA encoding the spike protein are encased in fatty nanoparticles. Your own cells read the RNA and make the spike protein, training your immune system.
Like Moderna and Pfizer-BioNTech.
Precisely. Moderna's mRNA 1273 was actually the very first candidate to enter clinical trials, a major breakthrough for the technology.
And DNA vaccines.
DNA vaccines are similar in concept to RNA, but use DNA encoding the antigen. The DNA needs to get into the cell nucleus to be transcribed into RNA first. India's Zydus Cadila developed one of these. No licensed human DNA vaccines existed before COVID, though.
Interesting. And the last type?
Viral vectored vaccines. These use a different harmless virus, like an adenovirus, as a delivery vehicle or vector to carry the gene for the SARS-CoV-2 spike protein into your cells.
Like the Oxford AstraZeneca one?
Yeah. Exactly. That one, manufactured in India by the Serum Institute as Covishield, uses a chimpanzee adenovirus vector. The Russian Gamaleya vaccine, Sputnik V, used 2 different human adenovirus vectors, a variety of clever approaches.
Given that incredible pace of development, the natural next question on everyone's mind back then was, when could we actually expect the first vaccine? And what about the major challenges looming, like achieving herd immunity and dealing with potential virus mutations?
Yeah, those were huge questions. The book, written in late 2020, highlights that early 2021 seemed possible for some limited vaccine use, perhaps for high-risk groups first. But it was anticipated to take maybe 2 to 3 years for sufficient global vaccination to really control the pandemic worldwide. A massive undertaking.
And herd immunity. Could we reach it through natural infection?
Well, on herd immunity, that indirect protection you get when enough people in a population are immune, India's national seropositivity data at the time the book was written showed only about 7% exposure nationally. Even though some urban pockets like slums in Mumbai showed much higher rates, maybe over 50%, the overall national picture suggested that relying on natural infection alone for herd immunity was still far. Vaccines were seen as essential for achieving predictable, widespread immunity.
What about worries that immunity might fade? The antibody drop.
That was discussed. Concerns about antibody drop after infection were noted. Yes, antibodies can decrease over months. But the authors point out this doesn't necessarily mean complete loss of protection. Other parts of the immune system, like memory B cells or T cell responses, might still provide lasting protection even if antibodies wane. The exact level needed for protection wasn't fully understood yet, though.
And vaccine effectiveness. Did it need to be perfect?
Not necessarily. Even a vaccine efficacy of 50%, which was the minimum bar set by regulators like the WHO, was considered worthwhile. It could still protect a large proportion of people, prevent severe disease, and significantly curb transmission. And first-generation vaccines could always be improved upon later.
How long would immunity last? From infection or vaccines?
That was a big unknown. The duration of immunity remained unclear. Reinfections, though rare at that point, had been documented, but reassuringly, most second infections reported were asymptomatic or mild, suggesting some level of protection remained.
And mutations, the virus changing.
Always a concern with RNA viruses. But the book explains that all RNA viruses mutate. It's normal. SARS-CoV-2, however, mutates relatively slowly compared to, say, influenza. Most mutations observed early on, like the D614G variant that became dominant, were found to have no significant effect on viral function, disease severity, or crucially, vaccine effectiveness. Constant monitoring was essential, though, especially tracking any potential animal-to-human transmission, like the mink situation in Denmark.
So the end of the pandemic. It depended on many factors.
Entirely. How well the vaccines ultimately worked in the real world, how long protection lasted, and critically, how quickly and equitably they could be distributed to reach billions of people globally. A complex equation.
As we look towards moving forward, what truly resonates as a core insight from this book is the author's vision for what comes after the immediate crisis. They aren't just talking about health policy tweaks. They're laying out a kind of blueprint for a healthier society, encapsulated in their powerful reject, revive, innovate framework. Let's break that down.
It's a very insightful and forward-looking framework, yes. First, reject.
Reject what?
This involves consciously shedding activities and societal norms that the authors argue contributed to the pandemic's emergence or severity in the first place. Things like unchecked deforestation, rampant and unplanned urbanization, which they bluntly call future disasters in waiting, and also the underlying drivers of non-communicable or lifestyle diseases.
Like poor diets, lack of exercise.
Exactly. Fast food culture, sedentary lifestyles, chronic stress, and critically ignoring mental health. It's a powerful call to reconsider some fundamental societal practices that make us vulnerable.
Okay, so reject harmful practices. What's revive?
Next, revive. This is about resuming economic and social activities, but doing so in a sustainable way, with a strong, explicit focus on improving conditions for the impoverished and most vulnerable populations who often suffer disproportionately. It also entails fundamentally transforming the health system, not just patching it up, but rebuilding it stronger. continuing initiatives like India's National Health Mission and Ayushman Bharat, but with a renewed focus on strengthening primary healthcare and public health services at the grassroots level.
Building resilience from the ground up.
Precisely. And finally, innovate. This is all about harnessing the power of science and technology, which played such a vital role during the pandemic to find new solutions, build better systems, and prepare more effectively for future health challenges.
That framework connects beautifully to what the authors call the essential fulcrums of epidemic and pandemic response. These are the key levers, the fundamental pillars, aren't they?
Exactly. The core elements needed for effective response and future preparedness.
What are some of the most critical actions they propose? Think about national, state, district levels.
Well, one crucial fulcrum is the need to mount a knowledge and evidence-based response. This has to be real-time, using data effectively, but also deeply understanding the ground realities, the local context. It requires continuous scientific and epidemiological research to provide insights, because strategies need to evolve as the science evolves.
Data-driven, context-aware.
Yes. They strongly emphasize the importance of preparedness and surge capacity. They note that Indian states with generally better funded and functioning health systems responded more effectively initially. So, sustained investment in robust surveillance and flexible capacity is key. Another vital point they raise is the often underused power of risk communication and community engagement, RCCE. Not just top-down messaging, but genuine dialogue, building trust and empowering communities to participate, essential for cooperation.
Makes sense. What else?
Fundamentally, they advocate for better government-funded health systems. The pandemic showed that publicly funded systems were generally more effective in mounting an early response and building surge capacity compared to heavily privatized ones.
Beyond just hospitals.
Absolutely. They stress that health systems are much broader than hospitals. They comprise 6 key functions working together: service delivery, infrastructure and human resources, financing, access to medicines, diagnostics, vaccines, health information systems, and overall governance and leadership. The ultimate goal is keeping people healthy and providing timely, quality care without causing financial hardship.
And funding.
A major point. They argue forcefully for increased government funding in health. India's spending was around 1.2% of GDP. The National Health Policy 2017 proposed increasing this to 2.5% by 2025. Globally, many countries spend 3-5% or even 8-10% in parts of Europe. They call health spending a social investment with high returns, estimating every rupee invested yields a 10-fold return to society through improved productivity and well-being. Plus, it's crucial for reducing India's very high out-of-pocket expenditure on healthcare, which was around 60%.
And more public investment is key.
And strengthening urban health governance, clarifying roles, empowering local bodies, fostering multi-sectoral collaboration, addressing staff shortages and salaries, establishing mechanisms for community participation and social accountability. It's a comprehensive reform agenda.
This discussion about systems and funding also touches on a concept central to equitable healthcare: universal health coverage, or UHC. How do the authors frame that?
They describe UHC very effectively using the analogy of a cube with 3 dimensions. It helps visualize the goal.
Okay, a cube. What are the dimensions?
The first dimension is population coverage. Who is covered? Ideally, all people have access to needed health services, with a focus on equity, ensuring vulnerable groups aren't left behind.
Everyone included.
The second dimension is service coverage. What services are covered? This should encompass the entire range: preventive, promotive, curative, diagnostic, rehabilitative services, all meeting acceptable quality standards. A comprehensive package.
The full spectrum of care.
And the third, crucial dimension is financial coverage. Protection from cost. This means ensuring no one faces financial hardship or is forced to delay or forego necessary care simply because they cannot afford it. Reducing out-of-pocket payments is key here.
It makes you realize how truly transformative achieving UHC would be, putting those 3 dimensions together.
Indeed. The authors paint a powerful picture. Imagine what achieving UHC would mean for a poor old widow living in a remote tribal village of India, as they put it. It would mean she has access to the health services she needs within an acceptable distance and time frame. She'd have some choice of providers, an assurance of quality care, and crucially, the confidence that accessing these services won't bankrupt her or her family.
That's powerful.
It's a vision of healthcare as a fundamental human right, not a luxury or a privilege determined by ability to pay. And to cap off these major takeaways, the authors offer something incredibly practical, a framework for what they call COVID-appropriate behaviors, or CABES.
Right, the everyday action.
Exactly. It's a brilliantly simple 2-3-2-4 approach that helps you integrate these habits into daily life. Easy to remember. And equally vital, acknowledging the huge mental toll the pandemic took, they provide a 1-2-3 Learn, Connect, Well strategy for supporting mental well-being.
Let's break those down. They sound like a personal roadmap for resilience.
They really are. Okay, first the CABs, the 2-3-2-4 approach. The two physical distancing behaviors are pretty straightforward. First, maintain a minimum distance of 2 gauge, which is about 6 feet, from others in public places. Second, greet without physical contact, namaste being the perfect example.
Simple enough.
Next, the 3 face and respiratory hygiene behaviors. First, wear a face mask or face cover correctly in public spaces, making sure it covers both your nose and mouth. Crucial because asymptomatic people can spread the virus. Second, avoid touching your face repeatedly, eyes, nose, mouth. Third, always cover your coughs and sneezes, preferably into your elbow or a tissue.
Got it. Mask, don't touch face, cover coughs.
Then, the 2 washing and sanitizing behaviors. First, wash your hands frequently and thoroughly with soap and water for at least 20-40 seconds. Or, if soap and water aren't available, use a 70% alcohol-based hand sanitizer. Second, regularly clean, sanitize, and disinfect frequently touched surfaces like doorknobs, phones, keyboards.
Wash hands, clean surfaces.
And finally, the 4 responsible social practices. First, discourage, minimize, and wherever possible, avoid crowds and large gatherings. Second, actively prevent stigma and discrimination towards patients, recovered individuals, and frontline workers. Third, educate yourself about COVID-19 using reliable sources and only share verified information. Don't spread rumors. Fourth, simply be considerate of others and their safety.
Avoid crowds, fight stigma, share facts, be kind. A good list.
It covers the key personal actions. Now, for mental health, the 1-2-3 Learn, Connect, Well approach. It starts with the 3 wells. Eat well. A balanced diet and staying hydrated are fundamental for both physical and mental health and support your immune system. Sleep well. Aim for 7-8 hours of quality sleep per night for adults. Try to maintain consistent sleep cycles. Exercise well. The WHO recommends 150 minutes of moderate intensity or 75 minutes of vigorous intensity physical activity per week for adults. For kids and adolescents, it's 60+ minutes daily. Gentle exercises like yoga, meditation, and pranayama, breathing exercises, are also great for mental well-being. And balance exercises are important for the elderly.
Eat, sleep, exercise. The fundamentals.
Then the 2 connects. Connect socially. Stay connected with friends and family, even if it has to be virtual. Share your feelings, listen actively to others, practice kindness. Social support is vital. Connect with nature. Spending time in open spaces, parks, or nature, if possible and safe, can be very calming and grounding.
Connect with people. Connect with nature.
And finally, the 1, learn. Learn new skills. Use any extra time you might have, perhaps from reduced commuting due to work from home, to learn something new, a language, an instrument, cooking, crafts, anything that interests you. It boosts confidence and helps combat the monotony that's set in for many.
Keep the mind active.
Exactly. These CABs and mental health strategies should be applied everywhere. Workplaces needing thermal screening and good ventilation, educational institutions adapting seating, providing mental health support, and using children as positive messengers for CABs. In daily life, too, gyms require extra distancing if masks aren't worn during workouts. Jogging outdoors means maintaining distance. Eating out involves assessing risks based on duration and crowding.
It's about adapting these principles to different settings.
Precisely. The book reiterates key facts. COVID-19 is highly infectious but mostly mild-moderate. Serious outcomes are higher for the elderly and those with comorbidities, and men seem to be at higher risk for severity. Asymptomatic transmission makes universal masking crucial. It's a multi-organ disease. Recovery takes time. Mutations happen, but generally didn't impact severity or vaccines early on. Interestingly, maybe 7 out of 10 confirmed cases don't actually transmit the virus. Transmission risk is higher in shared long-distance transport than even within households sometimes.
Useful reminders.
And remember, antigen tests detect current infection. Antibody tests detect past infection. Thermal scanners only detect fever, not the virus itself. Chlorine in swimming pools is believed to kill the virus. And just wash fruits and vegetables with clean water as usual. Basic hygiene works.
This has been a really comprehensive deep dive. It truly shows the incredible complexity, the scale, and the deeply human dimension of fighting a global pandemic like this. It's clear that while the virus brought immense, unprecedented challenges, it also really highlighted the power of science, the importance of collective action, and ultimately, human resilience.
Absolutely. The authors conclude on a note of cautious optimism, encouraging all of us to embrace a new normal. to actively reject those practices that harm our planet and our health, making us vulnerable, to revive our economy and social structures, but in a more sustainable and equitable way, and to continue to innovate using science and technology to build a healthier future. They emphasize there is no need for panic. Instead, drawing on the lessons learned, there is much reason for hope.
So after this deep dive, what does this all mean for you, our listeners? Perhaps it's a powerful reminder that every small, informed action you take, wearing a mask when needed, washing your hands, sharing accurate information, it contributes to the larger collective effort. And maybe it's a reinforcement that a truly healthier, more resilient society is built not just on emergency responses, but on strong, equitable public health systems, sustained investment, and recognizing the quiet heroism of those working on the front lines every day.
Indeed. And perhaps here's a final thought to consider. If health is so fundamentally interlinked with the economy, as the pandemic starkly revealed, and if investing in public health truly yields such high returns to society, what shifts in both public priorities and maybe even our individual priorities might we expect to see, or perhaps what shifts should we demand in the years to come?